Thank you. So, in the next 30 minutes, we are going to discuss if you really are able to decrease the rate of preterm birth. It's a difficult job to talk about that, but if you are not able to decrease the rate of preterm birth, we are not going for the target of the World Health Organization. We have to decrease the mortality in the first year, and in order to do this, we have to decrease the neonatal morbidity and mortality. And to decrease mortality in the first year, I have to decrease the incidence of preterm birth. So in the next 30 minutes, we are going to discuss this. And the most important thing nowadays, when you talk about perinatology, is malformation, fetal malformation. The second thing is the impaired placentation. And the third thing is premature delivery. So it's quite important to reduce the rate of preterm birth. And in order to do this, first of all, it's important to divide the preterm delivery in elective or iatrogenic preterm birth and spontaneous preterm birth. But before that, let's have a look in the incidence of preterm delivery in the last 15 years. There is no reduction in the last 15 years when you have a look at this picture. The rate of preterm delivery less than 1.5 kilos, less than 2 kilos, and less than 2.5 kilos is almost the same in the last 15 years. How, Eduardo, you are going to tell us that it's possible to reduce preterm birth if no one could do this so far? First of all, we need to have a look in this picture here. There was a slightly increase in the rate of preterm birth less than 1.5 kilos. There was a slight increase for those born less than 2 kilos, but there is a exponentially increasing in the rate of preterm birth less than 2.5 kilos, which means that was higher between 2 and 2.5 kilos. There is increase in the rate of preterm birth after 34 weeks. And the most important reason for that is the increase in the iatrogenic preterm birth. We are very confident with the technology. We are very confident with the neonatal intensive care unit. We are very confident with ventilation. We are very confident with steroids. And therefore, we bring this baby sometimes earlier than it could be. So, if I want to reduce preterm birth, the first thing that I need is to decrease the iatrogenic preterm delivery. So, for that, it's important to have prenatal care efficient. And to have prenatal care efficient means placenta previa, I could go until 37 weeks. Prom, I could go until 36 weeks. Preeclampsia, light, I could go until 40 weeks. Mild preeclampsia until 40 weeks. Severe preeclampsia, if the patient is in the hospital, if I have the patient under control, I could go until 37 weeks. We are doing this in the University of São Paulo, and in 1/3 of case, we achieve 37 weeks. Of course, HELP syndrome, we should stop at 34 weeks. IUGR, if I have Doppler, if I can have a good surveillance of this baby, I can go until 37 weeks. And if I have gestational diabetes under control, I can go until 40 weeks. So if I intend to decrease preterm birth, I need to improve neonatal care, and I have to push those patients near the term. Well, the incidence of preterm birth in Brazil is about 6.6%. In São Paulo, where I used to be, was 8.7%. And in the Hospital das Clínicas, which is a tertiary center of University of São Paulo, the rate of preterm birth was about 26% once we had lots of high-risk patients. So here is the whole population. Here is a very high population, very high-risk population. So in this hospital, we have a center, a department to look after babies, actually to look after moms with high risk for preterm birth. We start there. He is a hospital, and he is our chairman, Professor Zugaib. We start there in 1996, and at that time, the rate of preterm birth was 35%. 2002, we decreased this rate to 28%, where 50% of these were babies before 34 weeks. And in 2006, the rate of preterm birth was 18% in this tertiary center, and 1/4 was less than 34 weeks. Why you achieve this? I will try to show now. So first, if I want to decrease the rate of preterm birth, I need to have a good prenatal care, and I need to look after good diet and explain the patient the importance of BMI. I should give her good orientation about smoking, emotional control. I should give her orientations about her job, and I should diagnose and treat infection, vaginal infection and urine infection. But I need to identify risk factors for preterm birth, and there are lots of risk factors, but from these, I would like to highlight previous history of preterm birth, twins pregnancies, and short cervical length. 5 days ago, we had a chat with Roberto Romero, and he was very happy with the results of their study. And he told me, Eduardo, now we are going to be able to reduce preterm birth. My strategy for that is first, ask for the patient how is her cervix. And if the cervix is shorter, we are going to give her progesterone. And if you do this, I'm going to reduce the number of premature baby in US in 100,000 per year. This was his word. How can you ask for the patient how is your cervix? Como é o teu colo? Is right that? Como está o teu coelho? Well, it's easy. We can do like that. Take just 3 minutes. Take a vaginal probe, put cotton, patient, transvaginal scan, and then you can see the cervix. Identify the mucosa and measure from the internal to external walls. That's it. This is how is your cervix. And in 3 minutes, we can answer if the cervix is long or if the cervix is short. So we know that the shorter the cervix, the higher the risk of preterm birth. If the cervix is between 11 and 15 millimeters, 16% of preterm birth less than 34 weeks. Between 6 and 10, 22%. Less than 5 millimeters, 70%. Between 16 and 25 millimeters, 4%. I would like just to remind that the rate of preterm birth in the general population less than 34 weeks is about 1%. Which means that if the cervix is short, we are going to increase the rate of preterm delivery from 5 to 70 times. So maybe this is the best way, is the best approach in nowadays to identify those patients for spontaneous preterm birth. So, progesterone in previous preterm birth, the first question. There are lots of papers, and if we combine those numbers, we are able to reduce the rate of preterm birth about 25% in patients with previous history of preterm birth. When I talk about preterm birth, the chance of next delivery being prematurely, it's about 30%. But actually, if the baby comes earlier, the next pregnancy, this baby is going to be older than the previous one, which means that the risk is increased, but it's not that increased if you compare with cervical length less than 20 millimeters. But even that, we can reduce by 25%. So, if you take progesterone, you are going to reduce the rate of preterm birth less than 37 weeks for about 40%. You are going to reduce the rate of preterm birth less than 34 weeks in about 25%. And you are going to reduce neonatal morbidity, and therefore we are going to reduce the cost of premature baby. Short cervical length. If the cervix is less than 15 millimeters, we can take 200 milligrams of progesterone between 24 and 34 weeks, and according to this study, we can reduce the rate of preterm birth from 34 to 19%, which means a reduction of 44%. Actually, we could do even better, because if you take patient with less than 20 millimeters and just give her progesterone, we are going to reduce the rate of preterm birth, but we are going to reduce, although the RDS, respiratory distress syndrome, from 7 to 3.6%, and we are going to reduce any morbidity or mortality from 13.5 to 7.7%, which means a reduction in the preterm rate of 45% and reduction and improvement of neonatal morbidity and mortality. What about twins? How you can improve outcome in twins? I know how. Avoid twins. This is the best way. Because unfortunately, progesterone does not work. This is an old history that came back again in 2007 with 661 patients. They took 17 progesterone, and there was no reduction of preterm birth, less than 35, less than 32, less than 28 weeks. Unfortunately, we are not able to reduce preterm birth in twins. We need to get advice from the ECOG. And ECOG said in 2008, what should you do in order to reduce preterm birth, spontaneous preterm birth. First of all, we should offer progesterone for patients with previous history of preterm birth. You should give progesterone for patients with an incidentally cervical length less than 15 millimeters. However, at that time, they didn't recommend routine cervical assessment scan. Unfortunately, there are no evidence for progesterone in twins pregnancy. But if you really want to change numbers, we need to start working with symptomatic patients. Because, unfortunately, about 40% of patients who will deliver their babe before 34 weeks or 37 weeks don't have any risk factor. But every single patient who will deliver spontaneously his baby before 37 or 38 weeks will have premature labor, will have preterm labor. So it's very important to play in this scenario, symptomatic patient. But in my point of view, the most important thing, it's not symptomatic patient in preterm labor. It's symptomatic patient in having contraction without any cervical change. Why it's important? Because this patient, most of the time, they have tocolysis, they have steroids, and we lost the right time to give steroids once these steroids is given unnecessary. So, for symptomatic patient, the most important thing, either to avoid preterm birth or to improve outcome given steroids, is to understand what means false labor and what means truly labor, and how you can do this. We can try to do this by evaluations of cervical length. If patient come to my hospital, come to the labor ward, and she's contracting, and the cervix is still long, this is not labor. Actually, there are a very good study about antibiotics in patients in high-risk group in order to avoid preterm labor. Oracle, Kenyon, Lancet, 2001. At that study, where they decide in patient in labor to give antibiotics, either antibiotics or placebo, only 15% deliver their baby in the next 7 days, which means that the clinician, like me, like you all, are not very good in diagnosing preterm labor. And just because you are not very good for that, we are going to give unnecessary steroids. And we know if you give unnecessary steroids, we are going to lose the time, and you are not going to repeat these steroids. We can take fibronectin in order to give the difference between false labor and preterm labor. So, in this study, Tso and Fuchs, where we had 510 patients in labor, according clinician, they check the cervical length. Here is the cervical length, and here is the percentage of delivery in the next 48 hours and 7 days. So, first of all, the incidence of preterm delivery within 7 days was about 8.5%, which means we are not very good in identifying patient in labor. However, when the cervix was short, and the cervix was short in only 17% of this population, we had 15% of patients delivering in 7 days. So maybe instead of giving progesterone for every single patient in labor, I should select by cervical assessment and give progesterone only for those with cervical length less than 15 millimeters. Another way, we can go for fibronectin, fetal fibronectin. Fetal fibronectin, it's a glycoprotein, and this glycoprotein is in the interface between the baby and the mom. It's like a twin gum. And if there is any inflammation here, the progesterone leaks to the vagina, goes to the vagina, and I can find, progesterone, fibronectin goes to the vagina, and I can find fibronectin in the vagina between 28 and 36 weeks. If the fibronectin is there, this patient is a high risk for delivery in the next 7 days. I'm talking about symptomatic patients. So, I took some studies, 1,941, between 22 and 36 weeks, and the rate of positive fibronectin was about 20%, and the rate of delivery within 7 days was about 7%. However, when we had positive fibronectin, the rate of preterm birth within 7 days was 24% against 2% in the negative group. So either cervical assessment, or fibronectin, you are able to identify the patient could be stay in the hospital and receive steroids. Fibronectin, the accuracy of cervical-vaginal fetal fibronectin test in predicting risk of spontaneous preterm birth in the systematic review of nearly 27,000 patients demonstrate that in symptomatic patients, progesterone positive increase the risk 5 times for the delivery within 7 and 10 days. And when fibronectin is negative, I can be comfortable to send this patient to home once the likelihood duration is 0.75. So now I have a patient. She is contracting, the cervix is long, or fibronectin is negative. What should I do? Maybe we could use progesterone in order to increase the effect of beta mimetic, because there are weak evidence, but the most important thing is to understand that there is a good relationship so far between progesterone and ritodrine. In this paper, basic research, the Pipkin group in UK got uterine muscle and check how was the effect of progesterone in this muscle alone with ritodrine. And on the first experience, they put the muscle in a box. They tried to start contraction by putting oxytocin. And once they had contraction, they start with progesterone. And progesterone reduces the contraction induced by oxytocin. In the next one, he had the same contraction, and he put ritodrina or ritodrina plus progesterone, and there was a reduction in the contraction in ritodrina plus progesterone, and they conclude that progesterone could enhance the effect of ritodrine. On the third experiment, they put progesterone in the muscle for 12 hours, and then the next day they tried to induce contraction with oxytocin. And they did they need 2 or 3 times more oxytocin to have contraction. So I'm trying to bring some evidence where we could use in symptomatic patient progesterone. Fabio Facchinetti, in 2007, performed this study with only 60 patients, where they took 17p in patient in labor. The patient in labor, preterm labor, the standard management there was atosiban, and then they randomized for 17p or placebo. They checked the cervix on the discharge 7 days and 21 days after, and he could find that 17p reduced the rate of preterm birth, and 17p was associated less shortening in the cervix when nothing was done. Why am I bringing this? Because if I have contraction and there is no dilatation, I have false labor. And this is quite common. I'm at home and the patient calls, "Doctor, I'm contracting." And then we ask her to go to the hospital and the cervical length is long. There is no dilatation. What should I do? First, we should try to find urine infection. And of course, treat. You should ask her for bed rest and to avoid sexual intercourse. We have to check fetal, you have to take fetal assessment by CTG, by fetal biofile profile. The treatment in the book is phenobarbital for this kind of thing, uterine contractions and no dilatation, 5 milligrams orally, twice a day. Or maybe we could try vaginal progesterone from 100 and 200 milligrams once a day. There are weak evidence that progesterone could play in this scenario. We are waiting for big studies in symptomatic patients. And if the patient is in real labor, what should I do? First of all, tocolysis, put the patient in the hospital, check again the fetal, do an ultrasound to check presentation, amniotic fluid, baby's weight, and then check for urine infection again. Give tocolysis if there is no contraindication, nifedipine, terbutaline, atosiban, because the most important thing, it's not tocolysis. The most important thing is steroids. Betametasona, 12 milligrams intramuscular, 2 times, or dexamethasona, 6 milligrams, 4 doses. but we need to find the right time to give steroids, because we cannot lose time. Well, the question is it possible decrease the rate of preterm birth? Well, we did. We believe that it's possible, and if it's not possible, forget World Health Organization. We are not going for the target of the millennium, at least for the perinatal mortality. But if you believe that it's possible, we need to play in two different scenarios. The first scenario is the iatrogenic preterm delivery, and for that, you should think about this. Avoid unnecessary premature delivery in this situation. The second thing is identification of risk factors. There are 3 risk factors that that are very important: previous history, short cervix, and twins. Unfortunately, so far, previous history and short cervix, progesterone. Twins, avoid twins. Instead, 3 eggs, just 2. Instead 2, just 1. It's important not the beta HCG positive. What is important is this babe at home with his mom. Well, I would like to think about life. And I will try my Spanish. Está escrito in the Bible que permanece a fé, la esperanza y caridade. Estos 3, pero el mayor de ellos es la caridad. Medicine is like that. We need to think like that. E assim, em medicina, temos el diagnóstico, que é uma questão de fé. El pronóstico, que é uma questão de esperança. E el tratamento, que é uma questão de demasiada frequência, um assunto de caridade. Pero el maior deles é el diagnóstico. E há que ser um diagnóstico preciso. É impossível predizer o curso e resultado de uma enfermidade ou para tratá-la de maneira satisfatória. The main thing is avoid unnecessary treatment. Make the right diagnosis in preterm labor. This is the main thing that I would like to deliver today. Thank you very much.